Welcome to Senior Moments, the show that we talk about all things senior, the good, the bad, and the utterly ridiculous. Today I have Cindy Poot with me. She is from Golden San Andreas Care Center. Welcome, Cindy.
Thank you.
You're
Thanks
welcome.
for having me.
Oh, you're welcome. I'm glad to have you here today because we're going to talk about a topic that I am going to be quite frank in saying I still struggle with parts of how we pay for long-term care and what long-term care actually is and covers. So
Yeah.
would you like to start out with what long-term care is?
Yeah. So I work at Golden San Andreas Care Center, and we provide skilled, custodial, or long-term care and respite services. So custodial or long-term care is essentially being in a facility that provides 24/7 clinical supervision and care. Something that would be a little bit more than if mom or dad were to take care of you at home. You would have your medications managed by a skilled nurse. You would have a doctor rounding in the event that there was any changes of condition. And it's typically paid for either by Medi-Cal, a long-term care insurance policy, or CalPERS.
Okay.
Or if people were to pay privately.
All right.
Yeah.
So how do I end up in a skilled nursing facility?
There are a couple different ways. So most of our referrals come direct from hospitals.
Okay.
So like Mark Twain, Sutter Amador, St. Joe's, or direct physician referrals. So like your primary care doctor, your ortho doctor might refer you to our facility. But typically, most of the ones we see are either from the hospitals or from hospice.
Okay.
Yeah.
So then the people you're getting from the hospital generally would be, so I went in, I had hip surgery, and for whatever reason, going home is not a good option for me.
Yeah.
Then they might refer me to your...
So if you say you have stairs at home, or you're in a remote location to where home health might not service your area,
Okay.
or if you're an elderly patient and have an elderly spouse that might pose a substantial risk to them.
Sure.
Caring for you, you go down, they try to help you, and then you're both injured.
Exactly.
So then the physician or surgeon might recommend you to come to our facility for short-term rehab. That would, for like a hip or a knee, you would come for wound care.
Okay.
Help with strengthening range of motion, or if you have stairs, car transfers. People don't think about that. Just the simple task of bending over and moving your laundry from the washer to the dryer.
Can be a challenge.
You don't think about things like that when you have a hip or a knee replacement, but that's what occupational and physical therapy would help you with.
Okay. And in that particular scenario, who's paying the bill?
Typically, it would be your primary insurance. So if you were coming in for a short-term, like an orthopedic referral, that would either be Medicare, a managed plan, United Healthcare, Blue Cross, HealthNet, or if they don't have that type of insurance, sometimes they'll come in under Medi-Cal.
Okay.
And then therapy might pick them up under their Part B benefit if they have it.
All right.
That would be an option. But ideally, if you were going to have an ortho surgery, then you would come in under your primary insurance.
And how long would the insurance allow me to stay for?
That's a tricky question because
Okay.
every case and every patient is different.
All right.
Their recovery time is different. It could be complicated with wounds or IVs. So someone that comes in straight for just a regular knee with no other complications, you could best guess, 10, 15 days, maybe 20.
Okay.
If it's a complicated admit, best guesstimate, I would tell people, is probably a 20, 25 dayer. But if you're coming in under your Medicare would cover typically 100% of that stay for the first 20 days.
Okay.
And then on day 21, you would start to accrue a daily Medicare copay, which is for everybody.
All right.
on that day, if you have a secondary insurance, they would typically come in and pick that up, but we would help you verify that prior to you coming. So
Okay.
any insurance related questions, that's what we're here for. We would ask the hospitals for that, and we would verify it for you so that you knew that up front.
Oh, that's really good to know.
Yeah. And whether you come to us or anywhere else, we would do our best to help educate you so that people don't understand that part of their benefit until they need it.
Absolutely.
And that's the scary part.
Well, it is scary. And then what happens if I get referred to you because, well, I had a fall, I injured myself, I went in for rehab. While I'm there, I get COVID. I no longer need the rehab because I'm through that, but now I've got COVID. How does that work?
It depends on your case and your insurance, honestly.
Okay.
So if you're Medi-Cal or Medicare, then we have a little bit more leeway.
All right.
So, if you're going home to an immunocompromised relative and it's going to put them at risk for you having COVID, then we're going to do our best, to show compassionate, diligent care and care for you and get you stable before you go home.
Okay.
If you're a managed plan, it's a little bit trickier because now post-COVID, they're a little bit more stringent on the COVID authorizations.
Sure.
So if you're healed from your wounds, you're healed from your antibiotics, that's where we come in and we try to do our best to convey to them any barriers that you might have.
Right.
To make sure it's a safe discharge for you to go home. But as long as you're exhibiting, symptoms or anything like that, we want to make sure that it's a safe discharge.
Right.
For you to go home.
So what happens if I, again, had my original injury? I'm through the original injury, but in the meantime, my cognitive ability has slipped. So it's no longer possible for me to go back home. What happens then?
Okay. We would kind of look at the whole picture. So was there a medication change that made that happen? Was there a urinary tract infection or a UTI that might have affected that? So we try to look at the whole patient-centered care to see what could have caused that. Did you have a fall, medications, UTI? Anything can alter your cognitive status.
Sure.
But if it's just a steady decline, maybe that was in play before you came, then we would try to follow up with your primary care doctor, see if there was a history of that. Anything that we can do to educate the family, or maybe the patient's still semi-lucid, but they just don't understand.
Right.
They know something's happening, but they don't know the gist of what's to come. Then we would try to educate the best we can, and then make sure they were aware of Medi-Cal.
Okay.
So we would walk them through that process, get them in touch with the right people to go over their financial situation, to make sure they have the tools to plan.
Sure, that makes sense.
Yeah. So our biggest thing is making sure we educate people. So even if we may not be able to immediately help you with this stage, we want to make sure you have the tools that you need before you have to get there.
Right. So then, let me ask you this. Do you have different kind of areas of your building so that you've got, I'm under the impression, and maybe I'm wrong, that you do have long-term care people that are there simply because it's dementia or Parkinson's or something like that?
Some debilitating,
Okay, so is there like a different section for them, and then you've got your wound care, and then you might have your, I don't know why else you go to long-term care.
We try not to have a dedicated wing per se, but we do have a majority of our rehab people on one wing. And then we have 2 other wings. We have 99 beds total.
Okay.
So we split, we don't split up anyone that has wound care needs or anything like that. The only time we would separate them is if there is an isolation need.
Okay.
So it's kind of everybody's intermingled. So there's different cognitive levels, different functional mobility levels throughout the building. Some are bedbound, some are wheelchair, some are able to walk faster than I do down the hall.
Yeah.
So we try to make sure that we put people together with compatible personalities or functional levels to
Sure, that makes sense.
for their quality of life too. You know, we
Right.
want to make sure that we're putting compatible people together.
Okay.
But we do cater to this community because there is no other place for them to go
Right.
for custodial. And at the risk of putting our facility in a bedlock situation to where we can't do short-term, we have to be somewhat selective and save some beds for our short-term patients.
Okay.
But we try to do our best to keep people from this county and this area here.
And then how does the cost share go with that? So I'm in your long-term care and I'm never going to leave most likely unless a miracle occurs.
Yeah.
How am I paying for this after 21 days?
We would help that discharge planning starts on day one.
Okay.
So the minute you come into our building, we're already thinking about your discharge plan.
All right.
You're going to be on emotional overload, so that's our job to help you kind of walk you through that process.
Perfect.
So we would sit down with you, go over your finances, have you sit with our business office manager. She's
Okay.
very good at what she does. She would explain any monies that you have coming in individually,
Right.
not as a family, your retirement, your pension, anything like that, that would be taken into consideration for your income with the state. And they'll sit down and go over all the fine details with you. But in a nutshell, they take your income minus $35, and that's what would pay for your stay or your room and board.
All right.
And they would transition you from what they call short-term or skilled over to long-term or custodial.
Okay.
Yeah.
And what would make the difference between somebody going long-term custodial with you as opposed to, say, an assisted living situation where it's not, you don't have the 24/7 nursing staff and you don't have a 24/7 doctor, but you do have 24/7
Okay.
staff that's available if you fall or if you need help during the night or if you need med reminders, that sort of stuff. So what's the criteria, or
Yeah.
how do people sort themselves?
So I've worked in both, and I have extensive experience in both. So one is considered assisted living or independent, and it's called an RCFE,
Okay.
residential care facility for the elderly. Ours is called a SNF, or skilled nursing facility.
Okay.
We do short-term and long-term care. So the biggest difference, and the easiest way to explain it is, one, the RCFE will do medication management. They do your meals, they do your laundry. They may do different levels depending on your care plan, but it's all private pay.
All right.
If you have CalPERS, or some policies may help offset the cost a little bit, but majority it's private pay. And they do have medication technicians, and they do have clinical oversight by a licensed RN,
Okay.
but it's not 24/7 nursing care.
Right.
Our facility, you are overseen by a medical director, a physician, any SNF, not just ours.
Right.
And you do have 24/7 licensed nursing care and supervision, wound care, IVs, anything like that. So
Okay.
depending on what level you are, you're going to get the same care. In the RCFE, they typically won't do anything over like a stage 2 or stage 3 wound.
Okay.
And I don't believe they can do IVs, but it depends on the facility. So I recommend, if people, I don't want to say, well, you have to go to a SNF.
Right.
Go and tour, ask questions. That's a huge life choice. You want to go see it. You want to walk around. You want to ask questions. You want to smell it. You want to see the reaction of the other residents.
Right.
You want to see, are they happy? Because if the residents are happy, then you can feel confident putting your mom there.
Oh, absolutely.
Yeah.
Yeah, so I did have a case where we had I did used to work for a assisted living place,
Yeah.
and we had a resident who had Parkinson's. He was very concerned about the cost because
Yeah.
his wife was already needing some care at home, so a little bit of help at home, and he didn't want to spend every dime they had on his assisted living housing and
Yeah.
leave her penniless.
Yeah.
So first he tried to stop taking some of his medications, and
no.
that didn't work. To save money, mind you, not,
Yeah.
that didn't work. So eventually he decided he didn't want to pay, and I think at that time it was about $6,000 a month for memory
It's
care.
expensive.
He went to a skilled nursing facility, and I'm guessing that saved him money because then Medicare would pick it up, or am I right about that?
If he came in for skilled care, the Medicare would cover. But if he went in to live there,
Uh-huh.
that would be custodial care. But that would be covered under Medi-Cal.
Okay.
And then if he was worried about his medications, they cover the medications. So
Okay.
he wouldn't have that out-of-pocket cost.
Right.
That's unfortunate. I'm sorry.
Oh, it was an unfortunate. It was an unfortunate situation, but I guess my confusion comes in with the criteria about how he could be at. Now it was kind of a choice. I don't want to spend the money to be here. I will go
Yeah.
to skilled nursing, but you don't just get to go.
You can't just say, I want to move in there. There has to be medical criteria.
Right.
To
So I'm
qualify.
guessing the Parkinson's was the medical criteria in that particular case.
Yeah, so if he had advanced Parkinson's, that's probably what did it.
Right.
Yeah.
Okay.
But typically, how it would work is any skilled nursing facility would ask for a referral from the hospital or hospice. But if they're coming from home,
Uh-huh.
then they would ask, because we can't request it, it has to come from the family
Sure.
or the patient. They have to ask their primary doctor or their kidney doctor or whoever it might be, or their oncologist, to send a what they call the last office encounter notes,
Okay.
because that would pretty much be essentially the same thing as a referral from the hospital. It would have your demographics, it would have your medications, it would have any labs or any significant changes that you discussed at your last office appointment. So that's what we would need, and then we would just have you fax that to us. We would have our clinical team review it, and then they would look for any diagnoses that may qualify you to come in.
And then I know I'm asking you questions that you
No, that's perfect.
you don't have like the real answers for. In this case,
do
because
my
I'm
best.
I'm giving you a scenario that obviously you're not familiar with, and I don't even know all the details. So, in his situation, let's say, and I'm just going to make some stuff up because I don't know. Let's say his wife has her own Social Security. She worked for a company. She has her own pension. He had a company pension, and he has his own Social Security. So he's in the skilled nursing. She's staying at home. Whatever costs don't get picked up by Medicare or Medicaid or Medi-Cal or his insurance company, then you would take whatever income
Whatever
he had,
income he has, minus $35.
minus $35, and then his wife would still be able to retain them. Would she be able to retain their savings accounts and things like that?
If they're joint, that would be something that our financial services would go over,
Okay.
because everyone is different. But if it's something that both of their names are on, then we would have to have them look at it.
Sure, that would make sense.
Yeah.
If nothing else, they might have to split it in half, or hopefully
Yeah.
you wouldn't take it all because it's in both names. But
And we would make sure that the professionals went over that with them so that they knew exactly what they had to do and felt confident with it. And ultimately, it's their decision whether they want to
sure.
make any substantial changes or not. But anytime it comes to money, we want to make sure you talk to our financial services
Right.
person. That way they steer you, they steer you in the right direction.
That's really good to know, and I'm glad that you've got somebody that is that well versed that they can help people go through that, because
Yep. I know enough just to get me in trouble.
exactly, that's how I feel
But,
too.
Yeah, I want to make sure that we're being forthright with people. So if I don't understand it well enough to explain it simply enough to someone else, then I'll direct them to the right person
Okay.
to find it. Yeah.
And am I correct in believing that people that own their own homes are not being required to sell them as long as
They're
one of the
not.
people is still
Yep.
living in there?
That's true.
And does that change if let's just say that the person is single, they're living on their own, they have their own house, but they do end up in skilled nursing and let's say the rest of their life,
Yeah.
then in that case, they probably would have to sell their house, or is that not right?
In that kind of situation, that's where it gets a little bit tricky, unless they have it in like a trust.
Right.
Yeah. So the financial services person would go over that with them to see if
Okay.
there's someone else living there, or if it is indeed either in a trust, or help them get it in a trust.
Right.
Yeah, but we can't do any money guiding or education. We can just provide you with the services that can do that for you.
Sure.
Yeah.
Yeah, that makes sense.
Yeah.
Okay. So
Yeah.
have we covered all the ways that I could end up in skilled nursing, or am I missing something?
Hospital referrals, hospice referrals, direct physician referrals, or if you know you're going to have a pre-scheduled surgery. It happens a lot towards the end of the year because people want to use their benefits before they
Yeah.
lose them.
Right.
So they'll schedule like an elective knee is what they call it, or an elective hip.
Okay.
It's not an emergent because of a fall, you're choosing to do it.
Sure.
You may say, oh, I'll be fine, I'm going to go home, I'm going to have home health. You call home health and they're like 2 or 3 weeks out.
Oh my.
Then how are you going to drive yourself to your doctor's appointments? How are you going to make sure that your wound's not getting infected?
Right.
So if that's a barrier, or it puts you at greater risk for infection or rehospitalization, you don't want to go to urgent care or the emergency department and expose yourself potentially to some other contagious agent that you don't need to be exposed to.
Right.
So typically people, if they were pretty high functioning before, then they may only come to us for maybe 5 days,
Okay.
a week, just enough to kind of help them with their range of motion. Okay, how am I going to bend over and put my shoes on?
Right.
How am I going to do this? It's basically a teaching thing for them to kind of give them that step of confidence to get home
Okay.
and keep them there. Our goal is to get you home and keep you there. If that
Okay.
can't happen, then we'll have a plan B and a plan C for you. But
All right.
our ultimate goal is to make you feel as competent and confident as possible to get you
All
home.
right. So we were talking a little bit before about, did you say you have regional people that are coming in and taking a look at
Oh, yeah.
things? And
So Avalon was purchased or acquired by Empress, operated by Evergreen.
okay.
They're going through, we just finished our CHOW survey and going through the official name change to Golden San Andreas Care Center. And we have excellent regional support. So we have our COOs, our regional clinical teams. They frequent all of our facilities, which I love. They provide us exceptional support. They are making some big changes
Okay.
in our building, in our company. I know we have some community reputation
Uh-huh.
to repair,
Sure.
which I'm sure everybody has some, but they're doing a really good job about giving us the tools, the support that we need, clinical education, and hands-on. They're boots on the ground. So they're actually at our building today. So,
Hey, that's good to know.
yeah. So they're trying to make a big difference, and not just saying it. They're showing it. So
Right.
for me, being a marketer, it's easy for me to sell something that I believe in.
Oh, absolutely.
You know? Yeah.
Yeah.
And I can wholeheartedly say this company they're doing right by the county, by the community.
Oh, that's good to know. And I think that having people come in and actually see the conditions and how things actually work, as opposed to looking at a report that somebody wrote up and then trying to make
Yeah.
decisions off that. I agree with you. Coming in and putting your boots on the ground is a wonderful way to do it.
And people ask me all the time with home health and hospice referrals too. They'll lay out a bunch of paper and say, which one? And I said, I go by what families tell me.
Okay.
If you tell me you had a horrible experience with this person or this company, it's like, well, what happened? Was it a misunderstanding? Was it a
Sure.
genuine concern? Do they know about it?
Yeah.
Can they fix it? That's how I refer out to families. Or if they'll ask me a question, I'm honest.
Right.
You know, there are some issues here, here, and here, but they also have this, this, and this. So I welcome questions. You know, people come to me with problems. It's like, okay, I can confidently say that every provider that we have up here, home health, hospice, and even our local hospitals, they're doing really well. There are some bumps that we've hit with some
I think that's
some providers, and I'm sure they've hit some with us.
right.
But communication, you know, we have really good communication sit downs, and that's really important. I can't express how important that is to have open lines of communication, especially with the hospital leadership.
Uh-huh.
So Deb Croy and Matthew at Mark Twain
Uh-huh.
have been extremely communicative with me and our new leadership. And then the leadership at Sutter Amador, they're great. They've welcomed us over. We've had our leadership teams there, gone over community concerns, community needs, especially with the dialysis center. That's
Oh,
a
yes.
huge thing, not just for us, but for everybody. But they're very receptive to Calaveras County too.
Okay.
Yeah.
Speaking of dialysis, now, if you do have a patient in your facility that needs dialysis, do you take them to dialysis, or how does that work? Or do they just...
Right now, unfortunately, we're not able to accept any dialysis patients.
Okay.
We do have families that have approached us and, you know, volunteered to provide transportation, but for us, in the event that, you know, heaven forbid something were to happen.
Exactly. It's all about liability.
Yeah, and then
unfortunately.
how would we get them there?
Right.
You know, it's all about their care and making sure that we can get them the services that they need.
Right.
And if we can't 100% guarantee that we can do it, we don't want to put them at risk. It's not
Sure.
right for the patient. So until we can figure that out,
Okay.
unfortunately, that's a speed bump for us.
It is. And they don't do dialysis at the hospital here, do they?
No,
Okay.
no. I wish they did.
Yeah. Well, I think a lot of people would wish that, and then they wouldn't have such a drive. I know some people go to
Yeah.
Jamestown. Some people are fortunately going to be able to go to Jackson now,
Yes.
you know, especially on the
Yeah.
north end of the county.
Yeah.
Yeah.
So as long as they're a new patient and they're newly established, then they're going to be able to be seen there. But they're not, from the last meeting that we had, from my understanding, they're not transferring any pre-existing dialysis to that new center.
Interesting.
Yeah.
Yeah.
But we're trying to schedule more meetings to kind of keep up to speed on the changes that they're providing, and that's including the hospital leadership and our leadership teams. Yeah. So
Yeah.
hopefully we got some good things coming, but yeah, if we have more transportation, that would be a good thing.
I think you're right. We just hit the nail on the head with that one.
Yeah.
All right. Well, thank you so much for coming today and talking to us. I'm a little more clear on the whole skilled nursing environment now than I was before we talked today.
Yeah. And we're looking at trying to do at least 3 or 4 educational meetings, depending on what the community needs. So
Okay.
I know right now it's like this type of insurance-related or care-related questions.
Sure.
But diabetes management and like cardiac care, this month is Cardiac Awareness Month.
All right.
So heart health, take care of your heart. Try to find ways to keep your stress levels down. You know, what makes you happy, what brings you joy, because stress is a silent killer and that will get you. So the biggest thing is trying to focus on programs this month for stress relievers. It's like, what do we need? Is it walks? Is it diet? Is it following up with our physicians? Is it implementing a new cardiac program?
Because it's staying off of Facebook.
Yes. Yeah. So we're trying to get some cardiac physicians up here to do maybe some educational.
Oh, that'd be wonderful.
Yeah.
Yes,
So-
let me know. We will definitely help you get the word out. And
Yeah.
if they want to come to a senior provider network meeting, that'd be awesome. We can maybe do a combination.
Okay.
You know, that'd be
Yeah.
great.
Yeah.
All right. Well,
exciting.
thank you everyone for watching the show. I hope that you got some good information. I know I did. Please like us and follow us wherever you follow us, and show up next time and learn some more.